recording. Okay. If you have questions, just speak up, or you can try chat. I may not see it. So anyway, yeah, we're on number 7, which was just miscellaneous reactions, and we did this thing called a multi-component reaction, which was a method to just combine a couple things sort of simultaneously. And as we discussed in that lecture, we basically attached 4 things. There's obviously a sequence that's followed, but by these things coming together, and the isonitrile serving as a nucleophile, and that being an electrophile, and this also being a nucleophile, that kind of combination of things, and also the carboxylic acid, that combination of things created a nice intermediate, synthetic intermediate, which is basically the structure of Lipitor with a little bit of more work that needed to be done. It was a cool synthetic approach. It's called the Uji, I think it's Uji reaction. Is an example of this multi-component reaction business. And basically they just did a couple more steps of chemistry. Oops, sorry. KOH, what did KOH do? KOH removed an amide. Yeah. This is ultimately lost in the synthesis in the next step, which is kind of weird. And I think what I mentioned in the last lecture also, let's just go back a little bit up, was that, why did they choose this isonitrile with the methoxy and the nitro? That turns into this, right? And then it's ultimately lost with KOH to make, well, when I say it was hydrolyzed here, KOH hydrolyzes the amide to make a carboxylic acid. So what was the rationale for methoxy 3-nitro? Anybody remember what I said? I see somebody said orthopara-director. That's not exactly what's going on, because orthopara-director would be like if we're using these things to attack another thing with the benzene, like in a kind of organic 2 reaction. It's called EAS, electrophilic aromatic substitution. So kind of like if you have that, right? Say you have that and you want to go attack something, then yes, that is a orthopara-director, that's a meta-director, yeah? And those things would combine their forces to basically attack something right there, yeah? But that's not what we're doing, because we already have this piece on there. So anybody else remember what's special about methoxy nitro? That gets attached right there, right? AR. I say it right there. It's easy to cleave, right? Which is kind of weird. I don't know. Somehow the methoxy and the nitro electronically improve the ability to cleave this amide, right? Because it's really hard to cleave amides. Amides are super difficult to cleave. They're just like way harder than an ester. Esters are pretty easy to cleave. The thing is though that this reaction creates an amide, right? It's the mechanism of the reaction will always create an amide. So given an amide, they want an amide you can cleave easily, because eventually they just want to remove this anyway. So that was the rationale for that. That was kind of cool. Okay, yeah, so anyway, KOH cleaves the amide. It cleaves the amide. And then HCl cleaves the protecting group here, the tert-butyl ester protecting group. And then they're left with basically carboxylic acid, a couple other things. Then they do something that is kind of magic. kind of magic. At least for this course, it's kind of magic. I'm calling it a weird cycloaddition, which is essentially this thing getting incorporated, those two carbons, yeah, incorporated at the position of this carbon and that carbon. So it's a cycloaddition. So these things kind of add to make a ring as the pyrrole, right? And yeah, I could probably come up with the mechanism for this. I didn't do it. The paper, which is whoops, sorry. Got my camera here. The paper again is ACS Medicinal Chemistry Letters 2019, page 389, 392. They didn't propose a mechanism either. They just said, yeah, we just basically mixed this with this and maybe a palladium catalyst or something, and out came the product, which is, that's cool because it's basically Lipitor now. The only other weird thing that I thought was, like, if we look at all the atoms, they all kind of map out, right? Like this thing gets kind of attached here, yeah? But when I say this was lost up here, the carboxylic acid was lost, what I mean was in the product, which is, that carbon right there is this carbon over here with the fluorobenzene. That carbon does not have the carboxylic acid. So somehow it got lost in the mechanism, and that's a little strange. I don't know. I mean, if we did the mechanism, we could probably figure that out. But the big thing though is it's gone, right? That thing is lost in the product, and which is important because they don't want it there anyway. So somehow mechanistically, the carboxylic acid gets lost. Okay. All right. What else? Okay. So then, lastly, they finally used another acid. What did the acid do? It deprotected the acetal. What's acetal? Where's the acetal? It's that. This is the protecting group for the two alcohols, right? So these two alcohols are protected up here through this thing called an acetal. ACETAL. Okay. Yeah. Acetal is a common protecting group for alcohols, also for ketones and aldehydes. Okay, so yes, there we go. That was the synthesis. And then the other thing I did, I'll just review the very last slide I covered. Which is just an interesting metabolic story of atorvastatin and statins in general as cholesterol lowering medications, was that the metabolism is a lactonization. Lactonizes. Lactones are cyclic esters. So this oxygen kind of attacks here, kicks off the OH, and it's all catalyzed by the enzyme cytochrome P450. 3A4, 3A5, and it makes the lactone, and then the lactone is further metabolized because there's benzenes. The benzenes get oxidized to hydroxybenzenes, 3-hydroxy, 4-hydroxy, and those are ultimately excreted. This paper describes this all. And then, but the weird thing, and a very common issue people have with statins, is that grapefruit juice contains things called furanocoumarins, which are just furans fused to coumarins, and they kind of prevent this metabolism. And the net effect is that Lipitor builds up in your body, and that's not a big deal, except if it causes toxic side effects. And so that's the problem, is that basically drinking grapefruit juice, I think a couple other citrus juices cause this problem. It's the worst of the grapefruit juice. And anyway, so, and there's some of the chemicals, the furanocoumarins, furan and coumarin. There's some toxic side effects. And anyway, I guess the conclusion was that there's other statins that don't have this problem. like rosuvastatin and fluvastatin and pravastatin. Interestingly, I mean, what's different here? I mean, remember with Lipitor, it's actually this right side of the molecule. It's the same. What's different is they have the pyrrole, that nitrogen with the 5-member ring, kind of over here. So, right. So the thing is that this can lactonize. This can lactonize the same way. And that is not inhibited by grapefruit juice, which is kind of weird because it's the same structure, right? Essentially, 2 hydroxy groups, carboxylic acid. So basically, this can break down the same way that Lipitor does and be metabolized in a way that is resistant to grapefruit juice and the furanocoumarins. So that's just that's a little interesting to me because I almost expect this part of the molecule to maybe be different, but it's actually the same as Lipitor. Okay, any questions on this? Kind of a cool story. And I think younger people don't usually have to take cholesterol lowering medication, but as you get older, it's like a very, very common way to sort of prevent like heart disease and things like that. So as you get older, you may very well be on these medications. And anyway, and then you'll hear more about the grapefruit juice thing. Okay, so let's move on to more pharmacology stuff. Okay. So some of this will be kind of this whiteboard style, paper style, and then we're going to move to PowerPoint here pretty soon. Maybe by next time, we'll see how fast we cover all this stuff. So we're kind of now into chem842 is the course. We're now in part B. Everything else till now was part A. And we're going to call this basic principles of pharmacology. So various aspects to like how drugs are introduced into the body and then how they have their effect. This is based on that thing called Pharmacology. Which was is posted on the iLearn site. I've modified it a little bit. This is created by the Tulane School of Medicine. Tulane University School of Medicine. And I've changed it a little bit here and there. I improved certain aspects of it, adapted by me. But the PDF's on iLearn, right? PDF on iLearn website. Okay, and but I try to follow the structure of it. So if you get that file, you can kind of read it and I'll follow the structure of it. Okay, so number 1, definitions and abbreviations. A couple of these we've already seen. IC50, of course, inhibitory concentration for 50% activity, which we've seen basically 100%, 0% activity of an enzyme or protein or something like that. And we would basically see with increasing the concentration, a dose response, right? And the IC50 is the 50% point. Okay, so we know about that already. So it's somewhere, this would maybe be 7 nanomolar IC50 or something for this drug. Okay, lower is better, of course, for IC50. EC50, of course, the difference between IC50 and EC50 has to do with, well, I mean, what you're accomplishing. IC50, you're inhibiting something. EC50 is maybe a more general term, but we usually use it to describe response, like response. And that could have, you could, rather than inhibition, IC50 is inhibition. EC50 is more a response, I guess. And so if you like, if we measure percent response, we have 0 response, 100% response, 1 nanomolar, 10 nanomolar, 100 nanomolar, 1000 nanomolar, and we get a response. The EC50 is the 50% point of that. 50%. Okay. And we often use this to measure like agonist potency, agonist. Okay, so we talked about that stuff already. But there we go. There's a review of EC50 versus IC50. And remember the concept of like ED50 versus ID50 as a measurement of dose. And we showed the kind of the normalization of converting a dose into a concentration, and that kind of depends on the total blood volume and things like that. Okay, so let's move on to two kind of key aspects of pharmacology, all right? So branches of pharmacology. First one is called pharmacodynamics. Pharmacodynamics, or PD, which is basically what it's saying, what does a drug do to the body? Okay, and we'll give some examples of this idea. Of course, it's closely compared to the concept, so we'll say versus the concept of pharmacokinetics. Which is essentially saying, how does a drug get into the body? How does a drug get into the body? And that's going to be the next topic. It'll be number 3. So we'll talk about pharmacokinetics in a bit. If this is PD, this must be PK. Okay, so PD and PK. All right, so pharmacodynamics usually has to do with kind of interaction of a drug with receptors, Is it a agonist? Is it an antagonist? Is it an inhibitor? Is it an activator? All those kind of things. Another way to say, okay, so let's keep going with pharmacodynamics now. Another way to say this is the study of the relationship between the concentration of the drug and a biological effect. That's a nice summary for the concept of pharmacodynamics. Some of the aspects that are important for pharmacodynamics are important things you need to know are site of action, which could be like a receptor or a protein or a DNA target. Well, actually, let's say site of action could actually be, there's more like tissue, I guess. So it's a tissue type. So is it tissue in the lungs? Is it in the brain? Is it in the muscles, etc.? So site of action is a little more general. Another question, of course, is mechanism of action. You know, what is the, how does the drug elicit this effect? Is it binding competitively? Like, is it binding reversibly? Is it binding irreversibly? Is it yeah, is it, I mean, those are the main things. I mean, is it being covalently attached to the protein? Those kind of questions. Of course, the next aspect is the drug target, and the drug target is usually a protein, or sometimes it's DNA or something like that. Sometimes it's neither, though. Sometimes the drug target is almost like we'll think about like antacids. Like what's the drug target of antacid? It's not a protein. Simple antacids are actually, the drug target is just stomach acid, right? So it's kind of a boring drug target, but an antacid can be used to treat heartburn and things like that. So sometimes the drug target is very simple. Okay, so what are some of the examples of drug targets? We'll just review a couple briefly. All right, so examples of drug targets, and I'll do this. Some of the ones we did earlier on, like miconazole. Remember those ones? Miconazole, econazole, sulcanazole. Anybody remember what those were? Early on in this course, we talked about it. We talked about the synthesis of them, the rough biological activity of them, but they inhibited something, and they inhibited essentially ergosterol synthesis. Ergosterol synthesis, which was basically antifungal, is a method to kill fungi, like on your skin or something like that. So these were antifungal drugs, I think they're often used as like a skin cream type thing. The specific enzyme was called 14 alpha. That's an alpha. 14 alpha, 14 alpha, sterol demethylase. Okay, so that was how they worked. They inhibited an enzyme that was involved in this steroid, and the steroid is a crucial component of the fungal cell wall. So if you inhibit that, well, then the fungus has a imperfect cell wall, and that might be sensitive to other degradation or attack. Okay, so what would we say that what kind of drugs are these then? Like, if you had to summarize what they are doing, they're inhibiting an enzyme, right? So we might call them an enzyme inhibitor. Enzyme inhibitor, yeah, they inhibit an enzyme. Now that's essentially a pretty critical detail in the pharmacodynamics of them. Okay, every drug has some kind of pharmacodynamic story. All right, cool. So what are the ones we have? Is a question? No. Okay. So we're still on number 2, continued. A couple others. Just from the examples that we saw earlier in the course, zidovudine, and which is called AZT. The NNRTIs. Non-nucleotide reverse transcriptase inhibitors that we talked about in the homework, and then RTIs. These inhibit. So the little line with the cross at the end is a way of indicating inhibition. Of course, they inhibit HIV-1 reverse transcriptase. And as a disease, this is useful as an anti-HIV medication. Cool. What other ones? Of course, we could say remdesivir. This is also an enzyme inhibitor, right? So we're inhibiting an enzyme. Enzyme inhibitor, right? Remdesivir, of course, is a similar kind of concept, but it inhibits a COVID-19 protein called RNA-dependent RNA polymerase, present in COVID-19. And this is an anti-COVID therapy. Or a treatment for COVID-19. Okay. Also, it's an inhibitor of an enzyme. It's just an enzyme inhibitor. All right. Then we also have like tamoxifen, which is not an enzyme inhibitor. Tamoxifen inhibits something, but it's not an enzyme inhibitor. Tamoxifen inhibited estrogen receptor, right? ER in breast tissue, as we described. So it inhibits a receptor. That's different than inhibiting an enzyme. This was used as a breast cancer therapy. And as we said, interestingly, tamoxifen, oh yeah, what's it called? If something inhibits a receptor, as opposed to inhibits like an enzyme, we call it a antagonist. So it binds to a receptor and causes a net a negative downstream effect. And basically the net effect is that it inhibits cancer cell growth in breast tissue. Okay, but the funny thing about tamoxifen was it is also an agonist. Also, in other tissues, it's also an estrogen receptor agonist, which is kind of weird and interesting, I'd say. Is also an ER agonist in certain tissues, including bone tissue. And but an interesting side effect of that, tamoxifen being an agonist of ER in bone tissue, is that it prevents bone loss. And you could I mean, that's very fortunate, because otherwise, if this was a universal antagonist of all estrogen receptor, it could actually kind of cause, inhibit bone growth or bone structure, and essentially cause bone loss or degradation of your bones, and that would be bad, right? So it's useful that, a little anomalous, but also useful, that it is an antagonist in some situations, it's an agonist in other situations. Okay, and I also mentioned as another example of there's an antagonist. Example of an agonist that I just mentioned in class was also rizatriptan. I mentioned it in passing. It is a agonist of serotonin receptor subtypes. So how do we show agonist? A good way, well, one way is draw an arrow and then have like a big arrow to suggest upregulation of the target. There's other ways to show this, but if antagonists and inhibitors are a little line with a cross, this is a way you can kind of show what an agonist would look like. And so, for example, rizatriptan is an agonist of the serotonin 1B and 1D receptors subtypes, and that was a migraine headache drug target. So one of the classes of migraine drugs are these triptans, and they basically are agonists of certain serotonin receptors, and that has an anti-migraine effect. Okay, cool. All right, so that is an example of some of the drugs we've talked about, and what the basic idea of, what target are they interacting with? All right, cool. Let's give a summary now of pharmacokinetics. So we're on number 2, now we're on number 3, branches of pharmacology. Pharmacokinetics. Which is what we said was basically, how do drugs get to the body? That's one way to say it. How do drugs get into body? Another way to say pharmacokinetics, okay, so we said, what did we say for pharmacodynamics? It was, what do drugs, pharmacodynamics was number 2, right? We said, what do drugs do to the body? You say, what do drugs do to the body was pharmacodynamics. So pharmacokinetics, you could say, how do drugs get into the body? Another way you could say, express the concept of pharmacokinetics, or PK, is rather than what do drugs do to the body, you could say, what does the body do to drugs? Because that's another way. That's an interesting question, right? What the body does to drugs. What the body does to drugs. So a lot of that has to do with metabolism, right? We've talked about cytochrome P450 a bit, and okay. Anyway, so what? Let's describe this in a little more detail now. Of course, to have a therapeutic effect, drugs must be present in the proper concentration. So, right, and what would that concentration possibly be? Maybe something around the IC50, or, you know, maybe a little more, you know. Well, I mean, the thing about it is you can often have efficacy at the IC50, but sometimes you might need a higher concentration to maybe completely destroy like a bacterial infection or something like that. But the IC50 is a rough guideline, I guess. Say IC50 is a reasonable guideline. Yeah. And of course, the drug has to get introduced into the body somehow. So there's a lot of ways that can happen. And then it needs to basically needs to reach the site of action. So that could be systemically, it could be throughout your body. It may need to get into the brain to have its effect, etc. And so there's a lot of issues related to that. PK, pharmacokinetics, basically has 4 processes that we got to talk about. PK deals with 4 processes. They're called, and we summarize them with the acronym ADME. Okay. What are these 4 things? You may have seen this. Some of you may have seen these in different courses, but it's a standard way that we discuss kind of, well, pharmacokinetics, right? PK. So A is absorption. AB, it's not D, it's AB. Absorption. D is distribution. M is metabolism. What's the last one? When the drug's done and needs to be removed from your body, it's excretion. So all of these processes are, this is the lifetime of a drug in your body. First it gets absorbed, then it has to get distributed to the site of action and drug target. Metabolism is the process by which the drug gets processed and maybe oxidized or hydrolyzed or modified so that can be excreted. And then excretion is the final process where the drug would be removed, and maybe by your kidneys, lost through urination or fecal matter, etc. Okay, so what's the difference between absorption and adsorption? Anybody know? Anybody know the difference? It's a kind of a weird distinction. Absorption versus adsorption. So absorption means it's kind of like soaked into your body, whether it's taken orally or something like that. We'll say soaked in. Soaked in. It's not physically soaked in all cases, but the big thing is it's imported. It's imported into your body, all right? So through some mechanism. Adsorption is a different concept, and that's like if you have a metal or like a surface of something, and a chemical could get adsorbed onto it, onto a surface. Chemical will coat the surface, coats the surface. Okay, something like that. It's a different concept. All right, absorption versus adsorption. A common example of this adsorption is if you have, this is just back to your organic chemistry. If you have palladium as a metal surface and hydrogen can get adsorbed onto it, so we have hydrogen or other things will absorb on the metals. This palladium, PD, metal surface, and essentially now H2 is on the surface. Okay, different concept, different words. All right, mechanism, of course, something like that. The palladium attaches the proton for hydrogen atom, and then the bond breaks, and then the other H goes to the other side. Okay, so absorption, adsorption. All right, so let's talk about these four things now. Okay, I'll go to the next page. Okay, we're going to first talk about absorption of drugs. All right, any questions so far? Okay. So we're still talking about pharmacokinetics, absorption. Okay, so the main things, I mean, the questions are like, how do drugs get into our body, right? We probably have a lot of ideas for that. I'm sure you've thought about that a little bit, experienced this a little bit if you've, as you've been treated by various drugs in your life. So the main types of absorption are oral or parenteral. Oral describes, of course, drugs that we take orally. Parenteral is everything else. Okay. Right. And these are routes of entry. So the drug gets into our body somehow. Sometimes drugs can be administered by different methods, depending on what sort of a therapeutic goal there is. Okay, so let's talk about oral first. If all of the others are parenteral, oral is also called, another name for oral is enteral. Okay, and the obvious, how does that makes sense? You would take a pill, but how does it actually get into your body? Anybody know? I mean, of course, it has to make its way eventually into systemic circulation, right? There's a few steps of physiology there. So at first would go into your stomach, and then through your intestinal linings, and then eventually reach your systemic blood circulation, right? Okay. So there's a lot of potential for this not working, because if your stomach breaks it down due to the acidic pH in your stomach, or it doesn't get properly absorbed into your intestines, the drug may not be very effective, or or partially effective. So oral, I mean, is ideal. We as humans, if you're trying to treat a disease or something, it's really nice to just take a pill and have a disease go away, right? So that's ideal, preferred usually. When will it not work? Like we said, well, if it drugs that aren't absorbed. Right? It might just be excreted directly, or never absorbed into your through your intestines. Other situations, it breaks down in the stomach. Right? The stomach is not a very friendly environment for a lot of substances due to the high acidity. So a lot of functional groups can get degraded, like amides. Amides can be degraded. There's also a lot of enzymes in the stomach, digestive enzymes and things like that. So while oral is the most ideal route of administration, it doesn't always work for everything. A good example of something that does not work at all for oral, I'll just say here, example. A good example is that that molecule Fusion. I don't know if you remember that. You can do Google or Wikipedia search for Fusion. So Fusion is a really, really cool peptide drug. Anybody remember what it was for? So it's a peptide. It's a big peptide. It's like 20 amino acids, right? 20 amino acids. It is a HIV fusion inhibitor. HIV fusion. Very cool mechanism of how it works. I had some figures on that earlier. Remember the idea of, like, you have HIV, you have a host cell, and the HIV has to fuse to the host cell, and then basically import all its contents, right? And there's a lot of biochemistry in that process. There's some proteins called GP41, a couple other GP things. GP41 is a big one though, and so it's a viral protein that kind of gets attached to the host cell, and Fusion interferes with that process. It binds to some of the protein structure of GP41 in a way that prevents HIV from fusing, right? So go look back at the cartoon diagrams that show that, and it's just to review that, it's pretty cool. And also, yeah, check out the structure of Fusion. It's a very long peptide. It's an incredibly efficacious HIV treatment. But you can't take it orally, right? Because it won't get absorbed. Peptides don't get absorbed orally. Okay, so that's an example of something that just will not work orally. So how would you take it? As a drug? You maybe take it IV, intravenous, maybe intramuscular. I think it might be an IV drug. I can't remember the second. So, but definitely not orally. Okay. What about any other types of general classes of therapies that you would definitely not take orally? So these are not absorbed. Any other ones you can think of? Any other, like Fusion is just a general example. What do you think?
Like insulins or?
Yeah, insulins. Yeah, anything peptide. Yeah, insulin. I think insulin is intramuscular, and that is great because IV is tricky, right? IV, you need to find a vein, and you need like a nurse or somebody help you with that. Insulin, of course, is taken intramuscular, and that's something that diabetes patients can just do themselves, right? So that's preferable. But yeah, peptide things, generally speaking, and insulin is a peptide. You can look at the structure of insulin. Anything else like that? Think about peptides, but also what's a peptide? If it's huge, it becomes a protein, right? What kind of protein drugs are there? I'm thinking about even like COVID-19, like monoclonal antibodies, right? Antibodies and things like that, right? And that's monoclonal antibodies are being used as a treatment for COVID, right? Regeneron, those kind of things. So yeah. Anyway, those kind of molecules, generally speaking, won't work orally. We wish that everything would work orally. Any other downsides to oral administration? Like this whole process of stomachs, intestines, is that immediate? No, it's kind of slow. It could take hours for it to eventually work, a drug to work its way through that. So if you need something kind of rapidly, a rapid effect, oral is not necessarily the best way to do that. Okay. So it's slow. Okay, so let's do some of the, the opposite of enteral, which are parenteral. Which is not through the intestines. I think that may be the formal definition of parenteral versus enteral, which is basically going through the intestines. I think I looked that up before. Okay, so parenteral in general would be something like some kind of injection or some type of alternate route of administration. So what are the options? Of course, IV, intravenous. Intravenously into the vein, right? And that requires some sort of medical skill. It's not something that people can necessarily get directly. There are, like catheters and things like that. There's ways that somebody could, kind of self-treat themselves if with the right drug and the right setup provided by like a nurse or somebody. This is great. I mean, it's direct, rapid response. It's very quick. Problem, just technically it's a little more challenging, but certainly in a hospital environment, yeah, almost everything's intravenous because they can very quickly get into your body. There's no liver passes through the liver, for example, and so it can kind of prevent like metabolism, first pass metabolism, which is like through the liver. Of course, IM is intramuscular. That would be, yeah, like insulin and other drugs that, I mean, it doesn't require finding a vein. And so people can kind of treat themselves directly, or it's just, technologically less complicated. Also like flu shots, right? So if you get a flu shot or a COVID-19 vaccination or something like that, of course, they just avoid veins and just inject it into a muscle, and very easy. Vaccinations, insulin, etc. Other ones, subcutaneous. You probably have heard of that. SC is the abbreviation. Subcutaneous, of course, means what? Under the skin. It's a little different than intramuscular because you're not going into the muscle, but it's basically a way that drugs can be just basically, you know, kind of put under the skin, and they can be distributed often slowly or like a time release type administration. A lot of continuous release birth controls are done this way. So it can be done very slowly. Birth control medication. And yeah, it's often used for sort of like slow release type regimens, I guess, right? Okay, let's see what else we have. Any others you guys know of? Other ways we can introduce a drug that are not oral, not IV, IM, or SC. Any other thoughts? Nicotine patch, yeah, and that is that's a good one, yeah. And yeah, that's the name of that. What's the name, the formal name for like a nicotine patch? Of course, it's transdermal. I don't know if there's probably an abbreviation for that, but transdermal is like through the skin. Yeah, nicotine patch is an example. So it's also kind of a slow release type thing that goes through the skin, and you can get like a low dose of nicotine as sort of an addiction therapy type thing. Transdermal can be used for lots of things. I think they use them for some, even like opioids, things like that, where they can do a kind of a gradual release. Other ways, like just thinking of like all the ways you've potentially experienced drug administration or heard about. What else we have? Nicotine patch. Any other ideas?
Like topical creams and ointments, or would that just be transdermal also?
That's like a subclass of transdermal. We'll call that. Yeah, topical creams. Topical creams. It is definitely transdermal. Topical, maybe like a local anesthesia. Yeah, transdermal maybe would be described like various kinds of patches, I guess. But these would be more of like a cream, like benzocaine. Have you ever had a sore toothache? Horrible, painful thing. Yeah, like antifungal creams, like we're talking about miconazole and stuff like that. Yeah, things like that. What else? Sublingual, what does that mean? Sublingual means under the tongue. Why is that exciting as a drug administration method? And this is actually this is very rapid. Really quickly gets into your blood, and it's kind of like oral. Yeah, sublingual and under the tongue. It's rapid, and it avoids all of that kind of stomach and processing and intestinal processing. So it gets pretty quickly into your body and into general circulation. Somebody mentioned like Claritin. So there's like Claritin formulations, vitamin D. That drug I take for my migraines occasionally, the triptans, rizatriptan. That's great because a drug like that, I mean, if you have a migraine headache, like you need relief kind of quickly, and getting the drug into your body quickly is very ideal. So that's another example of that. gases. Yeah. Somebody said gases. Yeah, totally. Yeah, gases, which would be, we'll say inhalation as a mechanism to absorb drugs. Yeah, totally. Inhalation. What are some of those things? And there are, inhalation is very commonly or historically associated with anesthetics. There's definitely a lot of historic anesthetics. Somebody said laughing gas. Yeah, N2O, nitrogen. Yeah, nitrous oxide. Yeah, I have that one on my list. A couple of the really early historic ones, of course, are diethyl ether, which is a simple molecule. Diethyl ether. The industrial solvent, right? It's an organic solvent. It's a very simple molecule. It was used like for, tooth extraction and things like that for 100 years or something. It's a very effective, mild general anesthetic. The biggest problem with ether was it's super flammable, right? Super flammable. That's one of the problems, but generally speaking, it's not very toxic, and it's effective as an anesthetic. But it, in the old days, your dentist would be smoking a cigarette while pulling your tooth out, and then the whole room would catch on fire or something. So you have to be obviously very careful with a highly flammable drug or a chemical like this being used as anesthetic. It was actually on the, we talked about the World Health Organization essential drug list, which is kind of like tried and true drugs for almost every condition. It was on the World Health Organization essential drug list until 2005. So it still has been used semi-recently, and it's actually very inexpensive too. There's probably countries that still use this because it's so cheap. Other ones kind of related. Cyclopropane, that's weird. Cyclopropane. That was an early one, kind of in the, I think it was discovered in 1881 or something like that as an anesthetic. It's a small cycloalkane gas. It was stopped in the 80s, I guess. Nitrous oxide, somebody mentioned laughing gas, N2O. What's the structure look like? Nitrous oxide. Kind of a weird molecule. I mean, of course, there's two nitrogens and there's an oxygen. So it'll be N, triple bond N, O minus. So it's N, triple bond N, O minus, and something has to be positive. What's the positive thing? The middle nitrogen. So it's N, triple bond N, O minus, and it's N positive in the middle, nitrous oxide. This is still used commonly in dentistry. It's if you have a teeth pulled and stuff, it's still used commonly. Relatively safe drug. A couple other ones. Let's see what I got. Other kind of gases. This one's kind of interesting. It's F. So it's trifluoromethyl. Chlorobromo. So it's trifluoromethyl and CCl, CBr. It's called fluothane. This is also a general anesthetic used in surgery. This is also on that World Health Organization essential medicine list. It was a WHO list. Okay. Let's see. A problem with molecules that have halogens. Does anybody know any problems with them? Problems with halogenated molecules that may kind of prevent their use, I guess. Imagine a molecule like this, or even chloromethane, which is CH3. Anybody know anything maybe toxic about that? Toxic effects of molecules that have halogen in them, like chloromethane, I don't know, iodomethane. Anybody know? Like what is, let's draw chloromethane up here. Not a or iodomethane. This is not meant to be on the list. I'm just saying, what's potentially dangerous about this, like in the lab? Like, is it okay to splash on your hands or something? Iodomethane. These are electrophilic, right? Electrophilic. And a lot of your molecules in your body, like your DNA, is nucleophilic. So DNA is nucleophilic. It's got a lot of lone pairs, and they attack and kick off things. Now you've methylated your DNA. And so these are carcinogens. A lot of these can cause liver damage and alkylate your DNA. Now these kind of drugs can be used, but not like in a kind of short-term surgical environment, but alkyl halides can definitely cause some liver toxicity and things like that. Is it okay for a short-term use? Yeah, but this isn't something that would be used like every day for a long period of time. It is very effective, very, very effective anesthesia. Okay, another one, and this is actually another kind of interesting one. Related. Difluoro methoxy. So similar kind of structure. Then we have, instead of CLBr, it's ClCl. This molecule is called methoxyfluorane. Also called penthrox. So I discovered this one in a kind of watching a TV show like this summer or pandemic, one of my pandemic TV shows. It's a pretty cool TV show. It was a kind of like a surf rescue type thing in Australia. It's called Bondi Rescue. It's pretty cool if you're into sort of, what paramedics do. It's sort of people being rescued on the beach from surfing accidents and stuff in Australia. But basically, when people have their legs broken or something from a kind of injury in the ocean, and they're being sent in the ambulance to the hospital, they'd be given this drug. It's called the green whistle. The green whistle. So it's basically like a short-term anesthetic that you would kind of suck on this little green whistle thing on your way to the hospital just to relieve pain from your broken leg. It's kind of a cool idea. It is just like alkyl halides. It is liver toxic. Is a little bit of liver toxicity okay? Yeah, it is. If it's a 30-minute ride to the hospital, a little bit of liver toxicity. Everybody can survive a little bit of liver toxicity. So, does it take orally? I think this is actually an inhalant. I think it's like a it's most of these fluorinated molecules are gases anyway. So the whistle is some kind of method to administer this gas in little small doses that you can kind of just suck on the little green whistle and then you get your dose. So if you Google that, you'll probably see that. And the TV show is actually pretty cool too. Okay, let me see. And I think we're almost done. I have one more just to add to our list of, we're talking about inhalation anesthetics. These are all anesthetics, but one more. What show was it? What show was it? The name of the show is called Bondi Rescue. Bondi is, I think, a beach town in Australia. Bondi. I think it was on Netflix when I saw it, and it's a couple seasons. It's really cool. It's just about that whole kind of like the rescue culture of beach rescue people, and how they did that all in Australia. And so yeah, kind of like a reality TV show, I guess, but related to beach rescue. Okay, let me show the last one on this list. Also Australian culture, which is kind of fun too. One more. Okay, thinking about in things that you might take as an inhaler that are not anesthetics. Any thoughts? Like
asthma medications, like
asthma
Adderall?
medication, exactly. Yeah, people that have like a asthma, and you take a drug that would like a bronchodilator, things like that. Yeah, a good example of that is albuterol. It's one of these kind of modern asthma drugs. These are all bronchodilators, so they dilate your bronchial pores, and they're used as asthma treatment, or COPD, chronic obstructive pulmonary disorder, similar kind of related disease. And the drug is it is a small molecule drug. That's not a gas. But it's kind of inhaled as sort of a mist, I guess, and you would directly inhale it directly into your lungs where it has its effect. I think this is a beta adrenergic agonist. I can't remember the second, but yeah, the main idea is it's inhaled as a mist, right? Okay, am I done? I'm done. I think I'm done. Okay, cool. All right. See you guys. I will record the other continuance asynchronously. I think the next thing I will be talking about is a little bit about distribution, right? Absorption, distribution, metabolism, excretion, and some of the kind of issues related to drug distribution. Okay, cool. See ya.
Thank you.
Thanks.